Well, good evening and welcome to the first of our Ochre Academy webinar series. Tonight's topic is Better Billing, Understanding the MBS. My name is Caroline Rafferty and I'm the National GP Recruitment and Engagement Manager at Ochre Health. This evening, the presentation will be by Dr. John Hall, who is our Director of Medical Services at Ochre Health. In addition to his role at Ochre, Dr. John Hall is also the President of the Rural Doctors Association of Australia and has a wealth of experience in medical education and practice ownership. At Ochre Health, John is leading our vertically integrated educational program. I'd like to once again welcome you all to this evening's session of the Ochre Academy and introduce you to Dr. John Hall.
Thank you so much, Caroline, and welcome everybody to the first in our Ochre Academy series. It's great to be here, and we're really looking forward to kicking this off in what will be a really exciting series of educational webinars designed for doctors, within Ochre and doctors doctors out and about there that are doing their thing and whatnot. So at the end of the day, we're looking forward to producing some interesting and exciting educational content for people. As you'll see, bit of a poll has popped up on your screen, so feel free to answer those poll questions as we go. It'll give us a bit of an insight into where people are at. So if you want to get on and start filling in those polls as we go, that'd be great. As Carolyn said, I'm the current Director of Medical Services. I've been in the role since January, filling the shoes of Dr. Hamish Meldrum, who was in the role previously, and excited to be on board with Ochre Health, and in particular, on standing on the shoulders of what has already been a strong education program, and certainly some good work around health outcomes in Ochre Health as well. So kicking off, I'm going to go through a few things this evening. These types of talks around MBS and going through the detail often form the best part of a weekend. So this will be a whirlwind introduction into to whet your appetite into the interest around billing, the MBS, and some of the nuances, some of the risks and pitfalls around billing with the MBS and what we can look out for, and just some hints and tips, and we'll point you in the right direction of some resources as well at the end. So I'm going to talk a bit about why it's good to think about better billing. We have a fee-for-service funding system in the MBS in Australia, which is funded by the Commonwealth Government, taxpayers' money. And, we have a fee-for-service system because they know it drives productivity and it drives services. That's one of the reasons why fee-for-service exists. But obviously we know it's got its limitations. But there are lots of reasons why it's good for us as doctors to be better at billing, and that can be good for the patients, but it can also be good for us. I'm going to talk a bit about the professional services review, which is the policeman or the compliance arm of the MBS, and that's something that we all need to be interested in, and in terms of making sure that we're playing within the rules for our own protection. Talk a bit about the philosophy of billing, and there's interesting insights around how we bill and why we bill, and obviously there's a variance of practices with billing in the landscape of general practice in Australia, so it's good to think about that, and a bit about ethics as well. And then just going into some of the detail of the MBS, and this is where sort of the tips and hints and tips come in around things that we can do to try and maximise our billing. And again, as I said, I'll point you in the direction of some other resources at the end. This is by no means designed to be exhaustive. Also, a bit about billing policy, and each practice, whether you're working for a corporate or a privately owned practice, we all have billing policies and guides as to how we like to bill, ranging from universal bulk billing through to private and mixed billing. So it's interesting to think about that as well, and where we sit in the mix of that. And then a bit about procedures and procedural billing as well. why, as I said, why think about better billing? For me, and what I've seen in Ochre, Ochre, as you may or may not know, has had a long history, a proud history of being driven by patient outcomes. They've been measuring patient outcomes based on the Australian Primary Care Collaborative's data set for about 15 years and reporting on those and using them as key performance indicators for their practices and their regions. And what we see is when we bill appropriately and we bill better and smarter, actually it does have an impact on patient outcomes, continuity of care and the like. Also, we want to be valued for what we do as GPs in the landscape and looking at our relative value as specialists in Australian healthcare. We often are seen as being paid less as many of our other specialist colleagues, but if we are smart about how we use fee for service, we can certainly leverage off of that and be valued and value ourselves. And I think billing more appropriately in the community too also sets a value proposition for the community around the value of general practice. Some people try and leverage their billing or increase their billing by just really crunching high throughput. And we'll talk a bit about the 80-20 rule going forward, but one way of earning more money or billing better or increasing your billing, not necessarily better, is high throughput. But I've spoken to many colleagues that find that sort of work really stressful. The grind of high throughput, rapid fire medicine can be challenging. It's better to bill, particularly if you're a practice owner, it's better to think about effective and efficient billing for practice viability, particularly in the context of the indexation freeze. And I would say to you that, some of the biggest challenges with the freeze on Medicare rebates is actually hit the practices hard. It's that percentage, that service fee, that's really gets squeezed as things like medical inflation and wage inflation and wage increases go up. Often the amount that's getting squeezed is that practice service fee. So it's important for our own practice viabilities, and that's still important for contractor doctors. You want to be working in a viable practice that can reinvest in quality and good equipment, in paying your nurses and your staff well to create good teams and the likes, and that all helps to boost our the quality of our environment and our ability to be better doctors and do better work. As I said before, better remuneration, and also we want to avoid the audits. Just a slide to show you, this is an example of one of the quality data outputs that Ochre measures. We feed these back to our practices monthly. We collate them annually as well. This is one of the indices we use. It's the overall quality index. It actually packages up all the indicators into an index where we look at how we perform against the average. So the bottom green line is average, the red line is median, and the orange line there is what we know as the Ochre goal. So we're sort of aiming for better health outcomes, and as you can see, we do in Ochre consistently perform above average when it comes to health outcomes. And again, I think this is tied to smarter billing, better billing, and particularly when it comes to how we work in the chronic disease space. I'm going to talk a bit about compliance now, and this is something that we all fear to some extent. I think one of the risks with Medicare, and I'll talk a bit about this, is that there's a lot of things that you can bill, that it'll allow you to bill, that aren't necessarily appropriate. So it's quite easy to bill a whole lot of things that then you can come unstuck with, because there's not a lot of real-time checks and balances. But in the 2017-2018 federal budget, that was when they unfroze Medicare. The quid pro quo to the unfreeze was compliance, and they're wanting to claw back 103 million from compliance and debt recovery programs. And I'll show you my next slide, which shows you the massive increase in PSR activity, and so going from about 1 million in $1.5 million worth of recovery of monies from inappropriate billing in 2013 up to 29 million in 2018-2019 financial year, and that's set to rise. So the government certainly has its eyes set squarely on compliance. So it's something that we all need to be aware of. The other thing I think that's really interesting to note, and this has come in from the 1st of July 2019, is around the shared debt recovery. So previously, individual doctors and practitioners were fully liable for any inappropriate billing, but they've brought in shared responsibility. And I think this is really important for contractor doctors to understand, that it's absolutely the business of your practice owners, you know, whether it be a sole owner or whether it be a corporate, it's absolutely the business of your practice entity now to be monitoring and to be aware of the billing, because they're going to be liable for 35% of any of the inappropriate billing that goes on. So you'll probably see that, you know, whoever you work for, your practice entities are going to be a lot more interested in monitoring billing across the practice as well. This is particularly the case in, I think this came about because of the after hours issue, and there was quite a number of doctors that got stung through the after hours deputising services, and some of those entities were actually encouraging their doctors to bill inappropriately. So it's particularly pertinent if the organisation you're working for is not giving you proper guidelines, or is in fact encouraging you to bill inappropriately. And again, it's something to watch out for. You've probably all heard of the 80-20 rule. This is just to flag that there are data set points that the government uses to flag you know, whether you might be investigated. So essentially, doctors that are billing significantly higher than their peers, or actually achieving a much higher level of service than their peers, are more likely to be audited. At the end of the day, it doesn't mean that you're in trouble if you're audited. If you're doing the right things and you follow the guidelines and you're billing appropriately and you document what you do, then you'll survive an audit. But it's important to know that that there certainly are flags that will highlight people that will be assessed as to whether or not they need to be reviewed under the PSR. Interestingly, they're talking about in the rollout of telehealth, bringing in a 30-20 rule for telehealth. So the 80-20 rule is if you have more than 80 occasions of services across 20 days in a calendar year, and for the telehealth one, it would be more than 30 telehealth occasions of service per day across 20 days in the calendar year as well. So looking at people that are you know, potentially over-servicing across these ranges will be flagged. Because you're flagged by these data points doesn't necessarily mean you'll be audited. They will have a look at that and review it. Again, one of the challenges with Medicare is they'll often pay things even if it's not been correctly billed. There are some checks and balances in real time, as you would know, so some things get rejected, but there are many things that never get rejected, but they still might be inappropriately billed. So I think doctors need to be well aware that just because a billing's gone through and you get paid doesn't mean that it was an appropriate billing. And you've got to remember too that if you've inadvertently billed the wrong thing, or you have a habit of billing something that is inappropriate because you didn't know or you weren't sure, that can still be classed as fraud, and you need to be really careful about what you're doing there, because you're personally liable for that. This all is governed by the Health Insurance Act 1973, and it really highlights that you personally are legally responsible for the services billed, regardless of whether you bill it or the receptionist bills it or a nurse bills it on your behalf. It's always the practitioner that owns the provider number that's responsible for the billing. As I said before, Medicare monitors and audits practitioners electronically, and they look for inconsistent patterns or patterns where you're significantly different to your peers. So this is a cautionary tale of a GP that had to repay back to Medicare $269 And the point of this one was, and I think this is really interesting, whilst templates and shortcuts are really helpful to speed up our practice, and I certainly recommend them as a part of better billing, is and certainly getting good at your touch typing. But at the end of the day, if you use templates and you use the same template on every patient and you don't modify the template or personalize it, that can be used against you. And in particular, if they've got evidence that you didn't do all of the activities that were on your template. So simply putting templates into your practice software and saying you've done what you've done doesn't necessarily cover you, particularly if you're using them repetitively on different patients, and there's not much variation. So I would caution that as well here. But that's just a cautionary tale and if you go and you have a look on the PSR website, you'll be able to go through the cases of different things that doctors have done. It's quite interesting and I think helpful. So why, again, philosophy around billing, it's about working smarter, not harder. Again, we can earn good money and we can feel better about ourselves for providing a better service by spending more time with patients. In Ochre, we talk about dollar per consult. We measure dollar per consult and we monitor it. And again, it reflects increased activity in the consult. So it's getting away from just one item number per consult. It reflects people spending more time and doing more things with their patient and being mindful of what they can bill. So the Ochre average is around about $75 per consult compared to a national average of about $50. So you can see there that by leveraging off chronic disease programs and some of these billing techniques and tricks, we can actually increase our dollar per consult. I would also flag here that if you bill better and you bill smarter, sometimes you can actually earn money on a lower percentage than if you have say you had a higher percentage working on a contract in a low dollar per consult practice. You can often end up earning a total dollar amount that's less than working in a practice that fosters better dollar per consult, that fosters spending more time with your patient and doing more things with your patient, that enables you to do more procedures, more complex care and a broader range of activities. Often that can leverage your income as well. The other concept here is actually making sure that based on the time-based consults that we have, the attendance items, that we're not obliged to manage the full shopping list that a patient comes with in one consult. And I think we all tend to do that. We all want to please our patients, and we have a tendency to want to go through that shopping list. But one methodology that can again improve your experience as a GP is actually, someone comes in with a shopping list, you triage the shopping list, and from that consult you can actually plan future consults that might be, some of them might be longer consults. It might be that you're planning them to come back for a mental health plan. You might be planning for them to come back for a health assessment, where you could actually address some of those shopping list items rather than trying to squeeze it all into a 23 or a 36. And really you're underselling yourself, because some of those complex issues do take longer, they require more time, and it makes sense to actually look at, in a planned way, bringing patients back for multiple consults. So that's a really important, I think, principle here. It's one of probably the key take-home messages, I think, is looking at managing those multiple patient complaints and spreading them out over time and not feeling like you have to do them all at once. Again, knowing the MBS, I couldn't stress this more. Read it for yourself. I've got the link on the PowerPoint, and we can share the PowerPoint with the group today as well. It's good to read it, and certainly the explanatory notes at the start give you a lot of this insight into what the rules and regulations are around what you can and can't do. I'm going to be touching, scratching the surface of that through the course of the talk today, but I certainly encourage you to get it from the horse's mouth and read the MBS familiarise yourselves with the MBS and get to know it, and don't take advice from other people. Actually, make sure that you've got the evidence for yourself when you're making decisions around what you do and what you don't bill. I think it's really important that we provide services that are clinically indicated, and that we don't sort of have a billing mindset where we're just billing and doing additional services for the purpose of billing, that we actually think about what the patients need. There's so much need out there. Each of our patients, whether it be preventative medicine, whether it be lifestyle medicine or counselling or screening, there's a lot of work that we can do with each patient. We don't have to, I guess, be driven by trying to provide services because we can bill them. We should be driven by, what our patients need. And I think there's certainly enough need and demand out there to be able to do that and still bill effectively. And again, I think there is also an onus on us to actually be mindful that the MBS is, paid out of taxpayer funds, and we need to use it appropriately. I think the MBS freeze should speak volumes to people that the Medicare bucket of money is a finite bucket of money. So if we as a collective of doctors inappropriately or overuse Medicare, the government isn't just going to keep paying for it. They're actually going to do things like a Medicare freeze, or they're going to realign policy. So it's important that we do that appropriately, that we're billing appropriately, and that we can justify what we're doing, and that we are underpinning value for money for our community as well as our patients individually. So one of the other things that I guess principles or philosophies is Ochre supports mixed billing. I certainly had mixed billing practices prior to my role in Ochre, and I think the concept of privately billing and providing some bulk billing for the vulnerable is a really sound concept. We can make sure that we're driving towards a value proposition, but at the same time supporting and looking after, with a safety net for the genuinely disadvantaged. And again, we can tailor that to demographics. I also think it's a really good idea to have a standardised billing policy within your practice to actually, so your patients, your regular patients, have got informed financial consent. They know what they're in for. You've got good signage. I certainly have seen a number of practices where there's a really wide-ranging variance of billing policies between doctors, and I think that can cause confusion for patients. It certainly, can cause patient complaints and disgruntlement, particularly if they feel like they weren't informed and they end up at the reception desk and they're hit with a fee that's different or different to what they're expecting. But I think there's also the problem here that it can cause interpersonal conflict between doctors, and sometimes, for instance, a doctor might be in a mixed billing practice where some of the we're privately billing most of the patients, and then they're bulk billing healthcare card holders, pensioners, and children as per the bulk billing federal guidelines. But you might have one doctor that then chooses to universally bulk bill because they're trying to attract more patients to themselves, or whatever the reason might be. And I think it creates disharmony in practices. And I think it's a good rule of thumb to have to meet together as a practice, to talk to your lead doctors and actually come up with a policy that is known to the patients and the doctors and the nurses alike. So as I said before, really important to know the MBS. There's a link there to the most recent version of the MBS published in January of this year. It's important not to wing it. You often hear people saying, "Oh, just because other people do it, it's okay." That's never a defence. If you're brought up to the PSR, just because other people do it, not a defence. And don't delegate your billing. This happens in a lot of practices where people who feel like they're less sure of the MBS to say, oh, you bill it, or you pick the number to the nurse or the receptionist. This is, and it certainly happened in a lot of hospital environments too, in places where they've got 19(2) exemptions and they're billing Medicare through the hospitals. It's really important that you take personal responsibility, because regardless of who bills, the doctor who owns the provider number is the person that will be legally and financially responsible if anything untoward happens. And certainly there's been cases of untoward billing where the doctor themselves were completely unaware. Also, ignorance is no defence. So, not knowing the MBS doesn't help you. And there's been a few cases like that where people have pleaded ignorance or pleaded that the MBS is too complex, and it certainly hasn't helped them. Important that, so one of the key things that they look for with the PSR is adequate documentation. And it's important that your documentation actually explains and outlines and reflects that you've met the MBS item descriptors. So when you're building templates or shortcuts, important to make sure that you match them to the MBS descriptor. But also there's a follow through here that you actually do what you say you're doing in the template. So templates can be really powerful and really helpful if you make sure that they meet the MBS descriptor requirements, but also that you're actually doing what you say you've done. In that cautionary tale I showed you earlier, one of the things that doctor got pinged for was, in the template saying he was doing all this investigation, examinations, and there was evidence that multiple examinations actually never occurred. So you actually, if you say you've examined something, you actually have to do the examination, and be mindful that they actually interview patients when they're doing PSR audits. They'll ring a patient and say, did Dr. X do this with you on this day? So you actually have to do what you said you did when you're writing. So just documenting things isn't a complete defence. And making sure that your activities are within your scope of practice. I like this last point. I think this is really important. There's lots of upskilling that can be done that can leverage your billing. So looking at things like making sure being able to put in implant-ons, Mirenas, vasectomies, training towards the additional mental health item numbers, focused psychological counselling, the early pregnancy counselling item numbers. So there's a number of additional item numbers that you can access if you do upskill and you get the training. And certainly at Ochre, we strongly support professional development, and both financially and in principle, we support our doctors to build their skills. And we're actually looking at, through our innovation committee at the moment, looking at ways that we could leverage procedural practice. So the concept of day surgeries and that type of thing, be it metro or rural, looking at people working to the scope of practice, to the top of their scope of practice to the best of their ability. So coming right now into some of the nitty-gritty on how we bill. One of these concepts is how we can combine billing item numbers, whether it be bulk billing or privately billing. So when you're looking at combining different item numbers for the same occasion of service, the order in which you bill these item numbers matters. So if you're billing a number of different item numbers and their attendance item numbers, if you bulk bill the first item number, then any subsequent attendance item after that needs to be bulk billed. If you privately bill the first number, then other additional combination billings can be privately or bulk billed. So that gives you some flexibility. So it's really important to understand some of these underlying principles of combination billing. So in the example down below, if you're combining two item numbers that are unrelated and the second item is not an attendance item number, the non-attendance item number may be privately billed or bulk billed regardless of the first attendance item number. So the example there is, say we build 36 privately billed and then we build a pregnancy test, we could bulk bill that afterwards, or we could bulk bill the 36 and privately bill their pregnancy test. So there's nuances around how we bill different combinations. Important to understand that and to apply that when you're doing this. If you don't do this appropriately, many of these combinations will be rejected in real time. So it's important to understand this as you put your item numbers through and know, and again, one of the key take-home message, the order in which you write them and the descriptors that you put through your practice software do make a difference. So when you're looking at combining billing with mental health items, an attendance item can be billed in combination with a mental health item only if it is the first presentation. So if someone presents with depression and you're wanting to bill a mental health consult or 2713, then you discover they've got an abscess, or you discover that they need a blood pressure script, then you can't bill any of that additional stuff if the main presenting complaint is mental health. But if they present with an abscess and you manage that, and then throughout the course of the consult you realise that they've got depressive symptoms, then you can bill the mental health item number along with that as well. So again, there's some interesting rules, and it's good to be aware of these when you're looking at how you bill through Medicare. With this one, a slight variation on that is the second attendance can be billed with a mental health if it was life-threatening. So if you had someone came in, you're doing a depression consult, they developed severe chest pain, and you thought they were having an AMI, then you would be able to bill like an urgent acute item number after that as well. So there are some exceptions to that. And again, mental health care plans like GP management plans, chronic disease, shouldn't be billed on, cannot be billed on the first visit. Medicare will let you do this, and I certainly have seen a number of practices that dodgy practices where they'll see a new patient for the first time that's not known to them, and they'll put through a mental health plan. So often that will be paid by Medicare, but it's not legal. So it's another example of where sometimes things will get paid out, but it might not be legal. This slide's really interesting. This is some of the numbers that I crunched back in my own practice. So I used to own and run 3 practices on the Darling Downs in Queensland. And historically, we used to bulk bill all of our procedures. And we went through a process of actually analysing each procedure to real grainy detail to what the procedure actually cost us in terms of, and you'll see this in the middle column here, we looked at doctor time, so not just what the doctor was getting paid, doctor time, nurse time, the cost of a doctor. So that middle column isn't actually, again, what the doctor's being paid. That's actually the cost of providing all of the services for the room. That's more of the room cost, the on cost for the room. And then there's the nurse cost and consumables. The line in red here is just an example. That's catheterization of a bladder, looking at all the consumables. This, we highlighted this because this was even with a $50 gap. Basically, that was break even. Without a gap fee, that's a loss making. If you bulk build that occasion of service, that's a significant loss making event for the practice. And as contractors, you might say, so what, I'm getting my percentage. But it comes back to my point earlier, you actually need your practices to be viable. If your practices looked at this in detail, they might stop offering some of these procedural services because the cost, they're actually loss-making procedures. So in essence here, the problem is that the MBS is completely inappropriate when it comes to a number of procedures, and particularly the minor procedures like biopsies, some of these things like catheterization. There's quite a few procedures here where if you bulk bill, it's actually a significant loss-making activity for the practice. So this underpins one of my other themes here, and I actually have a view that I think all procedures should be privately billed. We went through an interesting experience with this in our practice. I practiced in a town called Ochre, which is a low socioeconomic area in outer regional Queensland, and we were actually quite nervous about moving to this. And interestingly, what we found was there was strong community acceptance of us moving to private, to a gap for every procedure. And in fact, we got busier. So when we were providing advanced skin cancers, flap surgery, vasectomies, marinas, implant-ons, the full broad range of procedural practice. And we essentially sent a letter out to the patients saying, Medicare, if we bulk bill these items, the practice, it's not viable. And so we can choose to stop providing the service, or we can charge a gap. And universally, they voted with their feet, and we got busier when we started charging a gap. And I think it goes to the point that sometimes charging a fee creates a value proposition and can sometimes, interestingly, drive increased activity. So that certainly was our experience. And again, that was in a very low socioeconomic area. I think the other key point here to remember that as GPs in the marketplace, if I do a flap on a nose for a patient, they might be $150 out of pocket, but there are other options in the market are spending $3,000 or $4,000 for a plastic surgeon to do the same job, or waiting for 6 months on a public surgical waiting list and having a registrar who's not trained in skin do the same job, or a general surgeon who's not specifically trained in skin doing the same job. I think we need to value what we do, and there's international studies that show that GPs doing skin work, diagnostic skin work, dermoscopy and procedural plastics actually produce equivalent outcomes. So valuing ourselves both economically, but you can see that that's a massive value proposition for a patient if they can get something done locally, and it's significantly cheaper than their other options. It makes sense to them, and I think again they vote with their feet. So I would highly commend looking at billing privately for procedures, and in your own practice is actually doing the sums, crunching the numbers on what things cost, and you'll be surprised. I know some doctors have a philosophy that it swings and roundabouts, and I might make some more over here in my chronic disease, and that'll pay for some of these other items that don't pay so well. But I think when it comes to procedures and the consumables and the cost of it all, I think this is an area where we can phase in some private billing that's palatable for patients. And you can do combination billing when it comes to procedures as well. Moving on now just to some better billing hints and tips around GP management plans. As you probably are well aware, you can't bill attendance items with these, and they're very strict about that. We used to be able to, but we can't anymore. But you can combine cycles of care, mental health care plans or mental health visits, and some procedures as well. So there are many options of additional billing that you can add on to chronic disease. And if you're smart and structured with this, and if you talk to your chronic disease nurses and your practice nurses, you can build systems where you're capturing all of those activities more effectively. There's things like ankle brachial indexes that you can bill for, and obviously ECGs, not so good anymore, but also billable in combination there. Health assessments, again, you can bill them in combination, as we said, but no co-billing of attendance items. And then medication reviews. It's important to know that if a patient is coming in for the sole purpose of a medication review, then no other additional items can be billed there. That's something that they're fairly strict about. Antenatal care is an area where there's a lot of opportunity for additional billing and combinations. So one of the common combinations is billing a mental health item with the antenatal item as well. But I would again caution you here that I think we need to make sure that the patient genuinely needs it or genuinely has symptoms. I think just throwing these two together because you can on every patient would be inappropriate. That it's actually important to make sure that any services that we do are indicated and justified and documented. The early pregnancy counselling and support number 4001 requires documented training. It was brought in around early pregnancy planning, making sure that women had the counselling and the support and the options for medical and surgical termination, but also for progressing with the pregnancy and other options and adoption and that type of thing. So strongly supported by the government and is a good addition, and it can be combined with the antenatal items as well. Again, one of those ones where I think we need to make sure that it's actually indicated, that we don't just tack it on to every antenatal visit. This is another area I think of opportunity. There are a number of services that we provide where over time the government has pulled back on, and they've taken away item numbers. So things like steroid injections and certain activities that we might want to do don't attract item numbers, but it doesn't mean we can't be smart about this. And I think this falls into a similar category to the procedural items. I'll recount our experience with skin checks. So in my practice, we offered advanced skin checks, and they were doctors that had dermoscopy certificates or diplomas in skin cancer. And we basically could only Medicare rebate the attendance item, so based on time, but we charged a significant premium on top of that. And that was sort of in line with a lot of what a lot of other skin clinics do. And this was an area where our skin checks became more popular, to the point where I had to pull them back because I got sick of doing too many skin checks and I was wanting to continue a diverse practice. So I think thinking about value proposition and charging appropriately for occasions of service that don't have an existing item number is a really interesting and important thing to do. This is just highlighting some of the other things that don't attract Medicare benefits, so you've got to be cautious. I think if you don't know this, you could easily and inadvertently bill for things that you're not aware of. But repeat scripts where the patient doesn't attend, you can't bill for through Medicare. You can bill privately, obviously. You can bill a sole private fee for any of these things, but we're talking about a Medicare rebate. So group attendances, family discussions, like nursing home discussions with the family if you don't see the actual patient. And as you know, many of the work injuries that fall under work cover and other medical examinations. So good to be mindful of things that don't attract Medicare, and I think really importantly too, services provided to our spouses or partners and dependents. For me too, this sort of highlights another ethical point, that we should really avoid, managing patients that are really well known to us. I think it's better to avoid managing our colleagues within the practice, people that we know really well. I mean, research shows that we perform poorly in people that we really, really like and people that we really, really don't like. So being mindful of that, of the ethics of that as well. Obviously, some challenges in rural areas where you're the only doctor in town and you have to manage your family and your colleagues and you don't have a choice. But certainly where you do have a choice, I think it's a good policy to avoid managing your colleagues and your friends and your family as much as you can. And that's certainly outlined in the AMA and the AHPRA Code of Ethics and in the soon to be minted Ochre Code of Ethics. Interestingly, there are some other screening activities that don't attract Medicare services. some of these like flying medicals, gun licenses, again, important to have good private billing policies in your practices for these, and certainly some of the pre-employment stuff, and those types of things. Screening services that do attract Medicare, so medical examination. So this is basically a very broad category in someone who doesn't have symptoms, but we deem as doctors that they might need it, medical advice to maintain a state of health. So that's a really broad remit and allows us to do a lot of preventative screening and medicine as well, lifestyle type medicine. So I think that's really helpful to know that screening is okay. So also age or health related examinations for licenses, medical examinations for people to become eligible to foster, and social security benefits, and for unemployed persons at the request of a prospective employer. So there are some loopholes there where we can bill Medicare. So that pretty much brings us to questions. I'm going to bring up the question panel now, and we'll go through some of those. I'm just going to bring that back, and we'll have a look. Okay, so we've got a question here. I think it's from Ross. Question I have is not individual billing, but why not better packages for rural GPs, especially in Victoria, and GP regs, retainers, which includes individual billings? Okay, look, I couldn't agree more. And the government is actively looking at this at the moment. So the whole concept of looking at single employer models where we might package up and realign programs so that we can go to market and better incentivize rural GPs and particularly GP registrars. And I do think, I mean, this will flow on. These concepts will flow on to metro as well. I don't think it's all about rural, but obviously we want to target rural because that's where the workforce shortages are most pronounced. But there certainly are models under trial at the moment in the Murrumbidgee Health Service District in New South Wales, where they're looking at a single employer where a doctor might be on a day rate or a salary from the health service, and they're packaging in all of the incentives, all of the the Medicare rebates that they might earn, and then what they might earn from the hospital, and sort of being able to build a better package. One of the things that I know is under consideration by government at the moment is really casting the net really wide and looking at all of the different rural incentive packages, programs, scholarships, ranging across a number of organisations, including rural health training units, universities, RTOs, workforce agencies, and the like, scholarship programs, specialist training pathway. We know to date about $2 billion is spent annually on additional funds and programs for rural, but less than $1 billion of that actually gets to paying doctors on the ground, supporting practices to the coalface. So there's a real appetite from government to look at how, without investing new money, we can actually build some packages, streamline programs and processes so that we can better incentivize and go to market. One of the things that's under reform is the workforce incentive payments for doctors as well, and looking at more of a tiered structure with the workforce incentive payments that would reward rural doctors for the activity of what they do. So you'd have a base rate. So if you were GP only, you got a certain amount. If you were a GP only and you did some on call in the emergency, you'd get a higher amount. If you had an additional advanced skill as a rural generalist, you get another amount, but that would all reflect the amount of on-call that you're doing, the skills that you're doing, so you could build packages that really reflect and reward people for doing the work. So great question, and I think it's actually a really exciting time to be involved in this space. I had a meeting with Minister Hunt on Monday, just gone in Canberra, with the Rural Doctors Association, and I can tell you he looked at some of these concepts and ideas and was strongly supportive, and was very keen to progress these types of models. And in the most recent federal budget, they've committed $3.3 million to looking at other innovative models of single employer. And interestingly, I think Ochre in some ways already does a lot of good single employer type models. In the Ochre sites where we support VMO hospitals in our Tassie footprint. I'm coming to you from Hobart at the moment. I'm looking across the way to the Royal Hobart Hospital across the block. We've got a number of sites in Tassie where we manage the hospital and the practice, and the GPs, the doctors are engaged by Ochre as a single employer, and we can package up their incentives and their pay in a much neater and more efficient way than I think other models work. So we're going to be putting to government the concept of single employer from a private practice point of view as well. Another question here from Pam. If I use templates to ensure I remember all elements of a child health check or travel consult, where does that sit? Look, I think that's perfect, and I think it's one of the other massive sort of benefits to using templates is actually as a memory jog. But I think that the caveat here and the key take-home message is whatever we put in the template we need to do, and it's very easy in the busyness of practice to overlook, to have in your template, I've done a blood pressure and then forget to do the blood pressure. So we need to make sure we're in the habit of actually doing what we say we do in the template. So I wouldn't have a problem with that at all. Hopefully that answers your question. Another one from Pam as well. I've seen spirometry done and billed every year for everyone with respiratory disease. A respiratory physician at a conference said that we should do one every time we assess a respiratory patient, like checking BP. But I don't do this. Any thoughts? Look, I think I've never heard of it being done every time you see a patient, but I think we need to be guided by evidence, and certainly, I would listen to a respiratory physician, but I think if it can be clinically justified, one of the descriptors, if you actually read the MBS, it talks about what clinical practice would be generally accepted by your peers as standard practice. That it's something along those lines, very, very similar words. So I think that's the take-home message here, is sort of testing it amongst your peers. Maybe if one respiratory physician said that, maybe you ring another one, or you have a discussion amongst your doctors, or you bring it to a medical coordinator meeting and we have a conversation about what the consensus is, because that's actually a line item. And if you could show that you actually you had looked into the consensus, I think you could back that activity up absolutely. Nursing home. So just looking at some more questions here. We've still got 6 minutes, so we're good. Make sure you keep the questions coming if you're out there and you're interested. For nursing home other case discussions, the patient is not present. No, you can't, and I touched on that. So this is a caveat. If you're discussing with the relative, but you haven't physically eyeballed the patient, you technically can't bill. You can. I've done this before where I've billed the relative privately, but you can't raise a Medicare rebate, unfortunately. And often they've got no appetite to pay either, so it's a tricky area. Skin check. Anonymous asks how much I charge for a skin check. We charged $150 private fee, and then they got a rebate back. Whether it was a 23 or 36 based on time. Is how we did that. But again, there's a variance of I think that was fairly conservative, or probably on the low end of the scale when you look at what people charge for skin checks. But I would sort of talk to your peers as well. Yeah, Shamila, I don't agree with that either. I think I mean, it's interesting as to why they've chosen some of these lifestyle or preventative things not to be covered. I think they're probably trying to. So you've got to understand the mind of the MBS and the PSR and the government. They put in price controls not because it's the right thing to do from a clinical point of view. It's because they're trying to manage the Medicare spend. So if you opened up the slather to say any weight loss management could be billed under Medicare, you'd have companies like Jenny Craig and those companies churning through item numbers. So they're thinking about the potential misuse or overuse of these numbers when they make rules. So I think you've got to be mindful of that as well, that often price controls are put in for the reason of managing the Medicare spend. I do think that there is, as I touched on in my talk, there's value in managing the Medicare spend. We have a finite bucket, and I guess government and the chief health officers and the department have a responsibility to make sure it's spent most appropriately. Sean from Kuma is asking, could you make the slides of the presentation available? Absolutely. Yes, for sure. So we will do that for you. No. No, you can't. So Reach is asking if we can charge a tray fee and then bulk bill procedures. This is absolutely and unequivocally not allowed. If you want to charge a booking fee or a facility fee or a tray fee, you just can't bulk bill. You can bill those additional fees and privately bill, but you can't do that and bulk bill. I know in our practice, we had a facility fee and we privately billed all of our procedures, and that facility fee actually went to the practice. And the doctor took a percentage of the rest because it was reflective of the fact that, again, as I showed you in my spreadsheet, the practice was taking a hit and sometimes making a loss. So you might find that, that's a useful thing if you're a practice owner to look at having a booking fee for procedures that goes directly to the practice, particularly for high cost instruments and for time. So any procedures that take a long time are chewing up nurse hours, treatment room time and consumables, and they can become quite expensive. So hopefully, Rita, that answers your question there. We're going to have to wind it up soon because there's quite a number of questions here. So I'll pick a few more and we'll get to as many as we can. Anonymous is asking about the 80-20 rule. So the 80-20 rule is actually the occasion of service. So I don't think they're counting how many items are billed. So it's actually patients in a day. I think that's my understanding there. I could be wrong, but that's my understanding of the 80-20 rule. I would commend you to looking at the MBS. They mentioned that as well there, or going to the PSR website. They talk in detail, and there's better descriptors on the 80-20 rule there as well. No. So Rita asking again about an annual fee. Again, these things have all been thought of and are outlawed. There are examples floating around where some practices have done some of this, but at the end of the day, it's all pretty much illegal. And the only way you can raise additional fees and bulk bill is, or you can't actually, you need to private bill. So you can raise additional fees and still privately bill, but you can't raise additional fees and bulk bill. There's been a couple of examples in Canberra where some entities did that. One was a not-for-profit, and I think they got an exemption because they were a not-for-profit, but as a rule, it's not allowed. Again, it goes to the point that just because other people do it doesn't mean it's right. So you've got to be, I commend you to know the rules for yourselves. No, that one's done. Done that one, done that one. Now, you, Jern Tan, I'm going to have to take that one offline for you. So my email address is there. If you want to flick me an email, I'll follow you up on that one, and we'll go through that in a bit more detail offline. But if you want to jot down my email address and flick me an email, I'm more than happy to answer that for you. And Anonymous asks if we can have a bulk bill and a co-payment, and I think highly unlikely. I think that just about wraps us up. We've hit on to the hour mark. Thank you all so much for coming. Really appreciate your time and attendance. Our contact details are there if you're interested in coming along to any more of these. If you've got any interest in working with Ochre or working with us at any stage or getting involved in our education programs, feel free to hit me or Carolyn up. We look forward to seeing you again, and yeah, have a lovely night, and stay safe. All the best.